السلام عليكم. معكم الدكتور ياسر الدرازي. أنا من مملكة البحرين. I am an endocrine surgeon. First of all, I would thank the organizing committee for inviting me for this lovely city, Sulaymaniyah. I really enjoyed it. The people are great. The food is great. I'm going to talk about... is this working? Okay. Yeah. So we all own our... this guy, which is called Emil Kocher, he's the guy who's the first surgeon who did the safe surgery for thyroid. In the 1800s, the thyroid complication was around 40%. And the mortality, as we see, around 8%. And this was mainly due to infection and hemorrhage. It was still then, in 1900, when Kocher came and with the meticulous dissection hemostasis, he reduced the mortality to 1–2%. Now, the thyroid surgery is a very complex surgery, by the way. And it had many structures nearby which could be injured. Mortality of the thyroid is much, much less nowadays, but other complication, it all depends on the experience of the surgeon and the level of competency of that surgeon. So when we talk about thyroid complication, the major one is like the hemorrhage, injury to the laryngeal nerve, and then we have hypocalcemia or hypoparathyroidism. Now, thyrotoxic storm, this is like in the old days, no more. And we have also minor complication, which is the commoner complication we see these days. Seroma, poor scar formation, sometimes some degree of voice alteration with mild dysphagia. So the hypothyroidism complication could reach transient hypocalcemia to 25 to 27%, while the permanent, it could be around 1%. Now, post-operative hemorrhage, it's between incidence 0 to 65. Normally, the post-operative hemorrhage in the first 24 hours. بالنسبة حق recurrent laryngeal nerve, if you are a surgeon who do surgery and identify the nerve, the risk is much less, like 0 to 2. While if you are not identifying the nerve during your surgery, the risk is higher, about 4 to 6.6. Now, the risk is even higher if you do a repeated surgery. So the risk of injury is between 2 to 12. Now, the other nerve also, which is also important, the superior laryngeal nerve, and injury to that nerve is like between 0 to 25. Now, how we prevent complication of thyroid surgery? Actually, this is like we start like pre-operatively, operatively, and then post-operatively. Pre-operatively, very important, you have to take a detailed history from the patient and about all his medication, especially if he's taking any warfarin, non-steroidal, any bleeding, and also in case if he has a big thyroid which is going to the chest, and if he has like a previous surgery in the neck, all this will affect the complication for that. So normally, preoperatively, I will ask about any medication, anticoagulant, warfarin, stuff like that. Very important also, if the patient is like Graves' disease, I would like first to control him before surgery. Another very important thing here, vitamin D, especially if like a big thyroid or retrosternal goiter or Graves' disease. I like to check that before surgery, because I have cases where they have what we call hungry bone syndrome. So I correct that before I do. Now, in my unit, I always consult with my colleagues. Sometimes we do like MDT. With a thoracic surgeon, I call them if it's a retrosternal, head and neck surgeon, if it's like there is lymph node metastasis, endocrinology, and all these people. We are all to work together. So the test I do before surgery, we check the thyroid function, thyroid antibodies. I check always the calcium and parathyroid. And for thyroid cancer, I do the thyroglobulin and the calcidone and CE. Imaging modality, number one, I do the ultrasound as always. If I find a big thyroid external, I do for them CT scan, and also for metastatic. FNAC also mandatory, I do for them FNAC. So this is like, sorry. Can I go back? Okay. Can I go back? Okay. So this is chest X-ray, as you can see. Like I do a simple chest X-ray. If I see this, I'll do for them chest CT. So this will help me to decide if I need a thoracic surgeon. By the way, more than 99 of the cases of rectal stenosis, I can do it through the neck. Very rarely, I use the thoracic surgeon with me. So also very important, preoperatively, I always check the laryngeal nerve. So many times, we'll have, especially if reoperated, they will have an injured nerve, which will be seen during this, despite that he is having a good voice. Now, operatively, what I do, the position is very important. So I put the patient on his supine with the sandbag under him, and then a jelly under the head. I don't hyperextend the neck because, especially elderly, this can affect their bone. So like this, I do. And then the scar, when I use a skin grease. I don't go like, whenever I see a skin grease, I use it. I've seen people who do a very low skin incision. But normally, I go with the skin grease. And this will give you a very cosmetically nice wound. Intraoperatively also, for the nerve, today we have an excellent lecture by Dr. Ebrahim and also my previous colleague. So that nerve, I always identified that nerve. I don't use intraoperative monitoring in my units. So usually important landmark, as we said in previous presentation, the tubercle of Zucker-Kandel, and also at the ligament of Berry. So tubercle of Zucker-Kandel, what I do, I retract the loop medially, and I will see that tubercle, which is always pointing to the nerve. So we have to understand the anatomy of the nerve and the variation. This is very important for a thyroid surgeon who do this. And it's had already, the previous presentation, they have showed excellent slide. So in particular, also, put on your mind the non-recurrent laryngeal nerve, which occurs in 1% of patients. Now, no portion of the ligament of Berry should be cut or clamped until the surgeon is 100% sure there is no nerve branch is within it. Very important, when I do dissection near the ligament of Berry, I don't use energy sources, no diathermy, nothing. So I only use clips and ties. So I always teach my resident, do not use the electrocautery near the nerve. And I also use the recent devices. I use ultrasonic or sometimes Covidian. So this is what I do. These are the instruments. I use them very often in every operation. Great care also should be taken if you have a bleeding. When you take suture, don't go deep so you don't injure the nerve. Now, the other modality to prevent injury, now there is a lot of talk about intraoperative nerve monitoring. And I think it is very helpful, especially if you have a recurrent disease which needs surgery, or if you have a very huge goiter. You can see intraoperative, the probe, they put it, and it is very easy. You can see it in the monitor. So a meta-analysis of intraoperative neuromonitoring for recurrent nerve policy during reoperation conducted by some scientists showed that it reduced the injury to the recurrent nerve. Overall, the recurrent nerve palsy rate was much less lower in reoperation conducted if you have this intraoperative monitoring. The other nerve also, which I would like to talk about, is the superior laryngeal nerve. It's a very important nerve. You have to keep, that nerve is usually supplying only one muscle, but it has a lot of implication. So we have to know the anatomy of that nerve, which is, we have here as shown type 1, type 2, and 3. Always when you ligate the superior pole, try to stay intracapsular. Don't go above. Because if you go above 1 centimeter, the chance of injuring that nerve is very high. And also, don't take bulk, make small for the artery. This will avoid it. Now, also, I've seen some other doctors, they use intraoperative monitoring for that. So, the other also, sorry. So this is all about. The other also complication that we should be aware is the injury to the parathyroid. And this could be done by several ways, either by excision, by mistake, or by devascularization, or mobilizing that one. Now, it is always advised when you do total thyroidectomy to check that specimen. So if you see a small parathyroid there, it is advisable that you remove it, cut it into pieces, and then implant it. So also you should know about the anatomy of the parathyroid. It could be thoracic, it could be intrathyroidal, it could be in the tracheoesophageal group, it's also at the base of the skull. So post-operatively, when I do total thyroidectomy, I always check the calcium the day of surgery, like 6 hours. Normally, when I do total thyroidectomy, all my patients, I give them oral calcium, 600 milligram BD for 2 weeks, and then I give them 1 tablet BD. This is to prevent transient hypocalcemia. This is my practice, and also the unit in Royal North Shore. Now, the new modality, people are talking about this indocyanine green. So is there any use to use that to identify? People are talking about that, but I don't have a lot of experience in that field. Another important complication is hemorrhage. And usually the hemorrhage occurs when it occurs the first 8 to 12 hours, to 24 hours. Now, in my practice, normally when I do total thyroidectomy, I put a drain for the first 1 to 2 days. There are some centers, especially where I work in Sydney, they don't put drain. So this depends. For me, I have to put a drain.
2 minutes. 2 minutes.
Okay. Now, also, to reduce, if you have a bleeding operatively, there is many ways to stop that bleeding. Many agents, Surgiflo, Surgisil. I use Surgisil for every patient. And at the end of the surgery, when I do my resection, I always do a Valsalva maneuver to see if there is any bleeding, that I catch it. So when I also close the strap muscle, I always leave like a small gap. So if they have a bleeding, it will come out. So as you see here. Now, the single most important thing, I think, in complication of the thyroid surgery is it should be done by a surgeon with high volume. That's why now thyroid surgery, by the way, is done by many specialty. We have the head and neck surgeon, we have the general surgeon, and we have specifically nowadays the endocrine surgery. So the more you do, the less complication. Despite all this intraoperative monitoring and all these things, I think the experience what matters. And thank you.